What's up, everyone? Today I'm doing a rapid review of Gaucher disease, the most common lysosomal storage disorder. Gaucher disease is an autosomal recessive inherited metabolic disorder caused by deficiency of the enzyme glucocerebrosidase, also called glucosylceramidase, which is encoded by the GBA1 gene. This lysosomal enzyme is responsible for breaking down glucosylceramide into glucose and ceramide. Because of this defect, glucosylceramide accumulates within macrophages, forming characteristic lipid-laden Gaucher cells that infiltrate multiple organs throughout the body. Gaucher disease exists on a spectrum, but it is traditionally divided into three major clinical types. Type 1 Gaucher disease is the non-neuronopathic form and is the most common, especially among individuals of Ashkenazi Jewish ancestry. Type 2 is the acute neuronopathic infantile form with severe neurologic involvement and early childhood death. Type 3 is the chronic neuronopathic form with slower neurologic progression and survival into later childhood or adulthood. The classic presentation of type 1 Gaucher disease involves hepatosplenomegaly, thrombocytopenia, anemia, and bone disease. Splenomegaly can become massive, and thrombocytopenia may lead to easy bruising or bleeding. Bone involvement is one of the most important and debilitating aspects of the disease and can include osteopenia, osteonecrosis, fractures, and severe episodes of bone pain called bone crises. A classic radiographic finding is the Erlenmeyer-Flass deformity of the distal femur. A high-yield teaching point is that the severity of bone disease does not always correlate with the severity of hematologic findings. Also, unlike type 1 disease, types 2 and 3 involve primary central nervous system disease. Type 2 Gaucher disease presents in infancy with rapidly progressive neurologic decline, including bulbar signs such as difficulty swallowing, stridor, abnormal eye movements, spasticity, and seizures. Death usually occurs by 2 to 4 years of age. Type 3 Gaucher disease also involves neurologic disease, but progression is slower. One particularly high-yield feature is horizontal gaze palsy, or ocular motor apraxia, meaning difficulty initiating eye movements. Seizures and progressive myoclonic epilepsy may also occur. There are also rare presentations, including a perinatal lethal form associated with hydrops fetalis and collodion or ichthyosiform skin changes, and a cardiovascular form characterized by calcification of the aortic and mitral valves, corneal opacities, and supranuclear ophthalmoplegia. Diagnosis is established by demonstrating deficient glucocerebrosidase enzyme activity in peripheral blood leukocytes or other nucleated cells, or by identifying biallelic pathogenic variants in the GBA1 gene on molecular genetic testing. One important thing to remember is that molecular testing can be complicated by the presence of a highly homologous pseudogene called GBAP1. Management includes both targeted therapy and supportive care. The major disease-specific treatment is enzyme replacement therapy, or ERT, using recombinant glucocerebrosidase. This can significantly improve anemia, thrombocytopenia, hepatosplenomegaly, bone pain, and overall quality of life. However, because the enzyme does not cross the blood-brain barrier, ERT does not effectively treat the neurologic manifestations of neuronopathic Gaucher disease. Substrate reduction therapy, or SRT, is another option and works by decreasing production of glucosylceramide. Examples include miglustat and eliglustat. Supportive management may also include pain management and orthopedic care for bone disease, blood transfusions for severe anemia, monitoring for pulmonary hypertension, and multidisciplinary management through a specialized Gaucher treatment center. And that's your rapid review. Hit that like and subscribe button for more quick study tips, and I'll see you next time.